Hi, my name is Dr. Kelly Roof, and I am a clinical educator here at Precision Analytical. And I just want to thank you for joining us today for yet another installment of the Dutch webinar series. Today, we're excited to welcome one of our very own clinical educators, Dr. Christina O'Brien, who will explore the powerful synergy of genetic insights and Dutch hormone testing. So, if you don't know Dr. O'Brien, she's a chiropractor, a registered dietitian nutritionist, an expert in women's health and autoimmune disorders. She earned her dietetics degree from Winthrop University and spent 10 years as an RDN in hospital settings before pursuing a Doctor of Chiropractic degree at Sherman College. She's board certified in functional neurology through the Carrick Institute and in functional medicine through the Institute for Functional Medicine. Dr. O'Brien is passionate about identifying the root causes of health issues by analyzing a patient's clinical history and establishing a baseline of their current health. She believes in the body's self-healing potential, and that understanding both past and present health factors is key to recovery. Her approach combines science with personalized care, creating individualized plans that may include dietary changes, hormone balancing, supplements, and pharmaceutical interventions when needed. Dr. O'Brien is committed to providing real solutions that address both the lifestyle and biological needs of her patients. So, today's session will explore how combining hormonal data with genetic markers can reveal unique, tailored solutions for two common yet distinct patient profiles. Number one, the burned out male, and number two, the perimenopausal female. Through two real life case studies, attendees will learn how to interpret and integrate complex hormonal profiles with genetic data to create individualized, effective treatment plans. This approach offers new strategies for addressing symptoms like chronic fatigue, mood changes, hormonal imbalances, and metabolic issues that commonly affect patients. This is perfect for clinicians seeking to refine their approach to complex cases, as this webinar promises actionable insights to improve patient outcomes in both men and women. If you're ready to start using Dutch testing in your practice, it's really easy. Just sign up as a registered provider today. Just click that link that we posted in the chat and complete our provider application form. A member of our onboarding team is going to walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, and one-on-one consultations with Dutch clinical educators like Dr. O'Brien and like myself. This dedicated support and education is designed to help you become the hormone expert. And we have some exciting news. Keep an eye out for the upcoming release of our brand new educational course, Introduction to Hormone Replacement Therapy, releasing in January of 2025. It's a pleasure to have you with us today, Dr. O'Brien. We really can't wait to hear what you have to say. Take it away.
Thank you so much, Dr. Kelly. I'm so happy to be here. Today, we're going to be talking about cracking the code of hormonal health with genetics and the Dutch test. We're going to understand the role of genetics in hormone balance. We're going to look at how to interpret the Dutch test through the lens of genetic markers. And then we're going to talk through developing some personalized treatment strategies based on genetics and hormones combined. And remember, the information in this presentation is provided for informational and educational purposes only. So, when we're looking at the Dutch test, we want to make sure that we are looking at things from the angle of not only what's happening currently, but as much as we can, individualizing our treatment protocols always to what is going to be ideal for the patient. And when we combine genetics and the Dutch test, it gives us a really unique view of what's happening with the patient's health. So, we're going to dive into today the powerful combination of genetics and advanced hormone testing to really understand how to best help people and get to the root cause of what's happening. And we're going to be looking at two different cases. We have the burned out male. And we have the perimenopausal female. And I chose those because they are, especially the perimenopausal female, being talked about quite a bit on social media today. And the burned out male, because we really, I feel like, are underutilizing testing in general for men. And I really wanted to hone in and focus on a really common phenotype that I see in practice, the burned out male, which um, that man usually shows up as someone who's really tired, who has really low testosterone and high estrogen, has a hard time handling stress. And we're going to talk through each of these cases so we could see what unique challenges each of those cases presents. And then look at genetics with the hormones to really figure out how to help balance neurotransmitters, how to improve hormone metabolism, and really ultimately how to improve stress resilience in these patients. And as we get started and jump into the slides, I want to acknowledge that genetics and hormonal health can feel a bit overwhelming, especially combining those two. When we start really diving into the specific gene variants, it can be a lot of information to absorb. But here's the good news: you do not need to memorize everything. I've created a couple of charts for you, these next two slides, and then we're going to circle back around at the end and look at these slides again. And these are going to be references that you can use, practical, quick reference tools that you can use after the seminar, looking at key genetic markers um, related to hormones, neurotransmitters, and detoxification pathways. So hopefully these will be helpful for you and you won't feel um, like drinking from a fire hose. When it comes to genetics, it can feel that way sometimes. And also when it comes to hormones, it can feel that way sometimes. So I want to try to make it really user friendly and simple, and just give you a unique viewpoint that we don't always get to see when we're looking at patients and overall care and really getting to the root cause of what's happening with them. So we are going to take a look at these two phenotypes in a little bit more detail and talk through the unique challenges that we face with each one of them. So the first one that we're going to look at is the perimenopausal female phenotype. This is the transitional period between being a cycling female and being a menopausal female with no cycles for a year. This time of life is can be erratic. Hormones fluctuate quite a bit. Neurotransmitter balance is often shifted. Mood swings, hot flashes, and brain fog are very common during this phase of life. Progesterone levels start to decline. That's the first thing we see in perimenopause, which lowers GABA support in the brain, which can cause more anxiety, more sleep disturbances. The adrenal glands, which are being asked to make hormones on the body's behalf, are generally pretty stressed out and not as resilient as they used to be after years of, in some cases, chronic stress. I would say in most cases, chronic stress. So adrenal strain and dysregulated hormone levels make it harder for the ovaries to make enough hormone to get us through this period smoothly. A smooth transition is the ultimate goal. We can see when we look at genetic markers for the perimenopausal female, we want to look at the CYP 1B1 and 3A4. And a lot of you who use the Dutch test already are very familiar with those pathways. Those are driven by genetics. And what we want to remember about the CYPs is that a genetic mutation can only upregulate, it cannot downregulate. So when we're interpreting these tests, we want to make sure we know that there are other things that can speed up or slow down these pathways, but genetics only can speed them up. And we want to look at COMT, which is very important. It is involved in the clearance of both estrogen and catecholamines. We want to look at their clinical presentation, which really is centered around mood changes, stress dysregulation, inability to handle stress the same way, sleep problems, brain fog. We also see weight gain, especially in the abdominal area when we shift from having more estrogen and more progesterone to having primarily more testosterone. We tend to see more weight gain in the midsection. I had a patient the other day who said, "I feel like I'm turning into a block. I don't understand what's happening. My middle is going away." It's very common in perimenopause and to menopause. And then we're going to look at some treatment goals for this patient. How do we help stabilize things so that there's a little bit more harmony and things are a little bit more even? The burned out male phenotype is probably the most common male phenotype representation that I see in practice. And these are men who are exposed to chronic stress, which shows us on the Dutch test a really distinct pattern of hormonal dysregulation and neurotransmitter imbalances. So we see from a hormone perspective, low testosterone, which reduces energy, motivation, and libido, which is made even worse by elevated estradiol. If there especially is an increase in aromatization of androgens to estrogen, we tend to see even more estrogen elevation in these men. And the shift results in overall estrogen dominance, especially a relative estrogen dominance, which makes them more tired, makes them have mood swings, increases body fat. And we also see a level of adrenal dysfunction in this phenotype as well. We see HPA dysregulation, poor resilience to stress, mood disturbances, also sleep disruption, and increase in body fat, neurotransmitter dysregulation. It's a very different presentation from the perimenopausal woman and the burned out male. And we're going to look at that a little bit more closely, what a fast comped versus a low or a slow comped does to the body and how the body manages both hormones and catecholamines when that happens, a slow or a fast COMT. And we're looking at genes like COMT for these, for this phenotype for these men. We're looking at the CYP19A1 and one of my very favorite genes, the FKBP5. The FKBP5 determines how well the body not only responds to stress, but how much cortisol and stress the body holds onto. How quickly can it let things go? So, this is a clinical presentation of fatigue, low motivation, mood disturbances, irritability, sleep disturbances, and disruptions. And our goal for the burned out male phenotype is to restore hormonal balance, create a better balance between that testosterone and estrogen. We want to support adrenal health, and we want to really look at neurotransmitter levels to help keep them more balanced from a neurological perspective. We want them to be um, more motivated, have better focus, and have more even moods in general. And ultimately, we want to help sleep in both of these phenotypes because there's sleep disruption in both. And what makes these phenotypes particularly interesting, I guess we could say, is when the perimenopausal female phenotype is married to the burned out male phenotype, which we very often see in practice. And when they're sleeping in the same bed and they're both having very different sleep challenges, but both sleep challenges. So it can get fun, right? As a practitioner to work with couples like this, especially because there's a whole lot that you can do for them to help them. So we're going to look at the genetic blueprint of hormonal health to see how genetic variants really shape hormone metabolism, how they help change our stress and our stress resilience and our body's response to stress. And then we're going to come up with some personalized interventions for both of these phenotypes. The genetic foundation of hormone health looks at several different areas. We look at the CYPs, which is the 19A1, the 1A1, 1B1, and 3A4, which again, we talk about a lot when we're looking at Dutch tests. We have the SUOX gene and the SALT gene. There are many different versions of all of these, but the SUOX essentially converts sulfites to sulfates, and the SALT inactivates adrenal hormones. So it's always really helpful to know what's happening with these. Are we deactivating or activating things like DHEA, for example, in the body? It can change the way that we approach things for the patient. We look at COMT, which we started to talk about a little bit. COMT is really important for breaking down dopamine and norepinephrine, which are the catecholamines that I referred to earlier, and catechol-estrogens. And the MET-MET variant slows down this process. So when we're looking at different genes and different combinations or presentations of those genes, it can really vary whether the COMT is actually slowing the process or speeding up the process. The MAOA influences serotonin and norepinephrine breakdown. GAD is responsible for converting glutamate to GABA. Glutamate is the excitatory neurotransmitter, and GABA, the calming or inhibitory neurotransmitter. We have BDNF, which is really important for neuroplasticity and stress adaptation. And variants in the BDNF are linked to stress resilience, similar to the FKBP5, where we see how well does the body really tolerate stressors in general. And then detoxification pathways are really important. There's a GST. We have a lot of different versions of that also, the GST, the GPX, and the SOD. And essentially, we want to try to figure out for the patient how to best neutralize their oxidative stress. And when we know what their genetic markers are, it makes it a whole lot easier for us. What we need to know about the Dutch test and other functional tests in general is that if we're not doing anything actively about a genetic presentation and we're not, let's say, on any supplements at all, or from a lifestyle perspective, not doing things maybe in the healthiest, I guess, in quotes, way, lots of different meanings to that word. But if we're not actively doing things to either inhibit or induce these genetic pathways or these pathways that are controlled by genetics, the functional labs are going to show us the genetic presentation for that patient. So when we see um, an upregulation or a downregulation in one of these pathways, we can assume, we may not always be totally right, but we can assume that there are genetic mutations on those pathways if it's not being influenced by other lifestyle, nutrition, medication, supplement factors. So when we're looking at detoxification, just like when we're looking at other pathways, it can become really challenging. And methylation is something I'm really going to focus on as we move through, because I find that one of the most challenging areas in practice. We kind of look at it and go, well, it could be B vitamins, it could be something else. And genetics really helps you to hone in really quickly on how to treat those pathways and how to really improve overall metabolism of hormones, and both sex hormones and adrenal hormones and neurotransmitters. And then we have those stress resilience ones. The NR3C1 is one that I did not talk about earlier, that encodes the glucocorticoid receptor, impacting how sensitively the body responds to cortisol. So, how easily does that cortisol attach to the receptor? And people with mutations on the NR3C1 tend to be those more wired but tired people. Those are people who have a lot of free cortisol in the body, but have a hard time actually using, processing, and excreting that cortisol from the liver. And we have the MTHFR, which, especially when we're looking at the Dutch test, and I'm reviewing the Dutch test with providers. Most of the time, we start talking about the MTHFR. If they have a question about that COMT pathway, the methylation pathway, they usually say, oh, I know the patient has a 677 or a 1298 on the MTHFR. And what we know is that it's really much more complicated than that. It definitely plays a role, but it's not the only one. And I'm grateful that a lot of labs are now doing the MTHFR genetics as a test, where a lot of these others are not accessible through standardized testing, or standard tests, I should say, like LabCorp, Quest. You really can't see all of these. A lot of them you can, but you have to order them all in a very, very different way, rather than a whole profile, or profile that's divided up into sections. So most people will have some knowledge of MTHFR, whether they have it or a family member has it. And I put it in the stress resilience category. We don't think about it necessarily like that, but it does impact your neurotransmitter production and stress tolerance. We talked about that FKBP5. It creates an exaggerated stress response and a really negative feedback loop that can cause prolonged cortisol elevation under stress, which is a terrible mutation to have. It's harder to eliminate stress in general. And then the CRHR1, that's the corticotropin releasing hormone receptor, regulates the release of ACTH, which we have a neat diagram on our test where we can see where ACTH is released and how that changes the production of adrenal hormones. And the CRHR1 regulates the release of ACTH in response to stress, which determines how the adrenal glands are going to function, how much cortisol is going to be produced, and how intensely, essentially, the body makes cortisol under stress. So, looking at genetics like this, and when we look at these all together, these genetic insights really reveal the patient's unique hormonal tendencies. It reveals their unique neurotransmitter balance and their stress tolerance, which really allows us to create a personalized and effective treatment protocol for them. I think about genetics like the handbook. Sometimes we're working on things in the way that we've worked on hundreds of times with other patients. And if we don't realize they have a genetic mutation on something we're not even thinking about, it can really change the patient's presentation and really ultimately their response to the therapy that we're prescribing for them. These are some more neurotransmitter metabolites. We have the HVA, VMA, and we have quinolinate and kynurenate, which I really wanted to focus on so we could see um, what those genes, or really what those markers are controlled by, what genes they're controlled by. Those are not genes that we commonly look at when we're talking about genes in general. This is much deeper when it comes to genetic testing and not as commonly looked at, but that's a really important pathway. And in the last couple of years, we added quinolinate to our panel. So we've always looked at kynurenate, and we know that when kynurenate is high, it's more than likely a B6 deficiency. But now we have the ability to see quinolinate. And the way that these pathways work is that tryptophan is the start of the pathway, the very top of the pathway, which moves through kynurenate. And kynurenate is B6 dependent. That's one thing that kynurenate is dependent on. There are other things, but if kynurenate doesn't have enough B6 in particular, instead of moving straight through the pathway from tryptophan all the way to NAD+, what we see is that kynurenate can sometimes take a left-hand turn into kynurenate where we really don't want it to go. And into quinolinate. So from kynurenate, instead of going all the way down to NAD plus, which creates energy for the body, there's a turn to the side into quinolinate. And quinolinate is a neuroinflammatory marker, and we measure that on the Dutch test. And when we look at the combination of HVA and VMA, which are also markers that we look at on the Dutch test related to dopamine and epinephrine, norepinephrine, and combine those with kynurenate and neuroinflammation, it creates a really powerful profile for helping people with neurotransmitter imbalances and neurotransmitter dysregulation. And we combine that with all of these genes, we know much more specifically how to help these patients to get hopefully better faster. Okay, so when we look at estrogen metabolism, this is what we're used to looking at on the Dutch test, and we talk about this a lot. The 1A1 is the protective preferred pathway. The 3A4 is essentially the second most preferred pathway, but is a more proliferative pathway. And the least preferred pathway is the 1B1 pathway. That is the one that can lead to things like reactive quinone formation, DNA damage, oxidative stress, etc. And those three make up essentially phase one hormone metabolism. And then that COMT enzyme at the bottom is what helps the body methylate. So COMT is really critical in detoxifying catechol estrogens, especially the 4OH, which is the harmful one. We need to clear those things out through the body. And when there's a genetic mutation, especially a slowing of the COMT, then it's harder for the body to eliminate those toxic hormone metabolites. So, supporting all of these pathways with nutrition is entirely possible, and we do those things all the time. We're going to talk more specifically about the 1B1 in particular, especially related to how to eliminate 1B1 and how to make sure that we're not inadvertently increasing the 1B1 if somebody has a genetic mutation there. So, for the COMT, we look at neurotransmitter production and neurotransmitter elimination. It is peripheral to the glutathione pathway, which also helps our body reduce oxidative stress in general. And it's really critical that we start to really look at managing oxidative stress, especially when hormones are shifting and when we're under chronic stress, in order to promote optimal cellular health and really optimal cellular resilience. And when we start to see shifts like women starting to go through menopause and men going through andropause, and we're seeing these shifts in hormones, we can really start to see these genetic markers surface in the functional labs. So when we look at methylation, we're looking at, again, not only MTHFR, but we're looking at BHMT, we're looking at COMT again, we're looking at MTR and MTRR, which works with B12 in the methylation cycle to convert homocysteine to methionine, which is really important for DNA synthesis and essentially repair. And we're looking at DNMT, which is the DNA methyltransferase that is responsible for essentially maintaining the methylation of DNA. It regulates DNA methylation. It influences gene expression and epigenetic stability. So, what we want to remember about genes is that when we're born with a genetic makeup, we're born with genetic mutations, they don't always fully express as something negative until we do things in life to um, impair those genes, make them work less well. So, drinking soda or being exposed to microplastics or EMFs or things that we do in life, um, not eating as healthy, being exposed to things in the environment, our genes become a little bit overwhelmed essentially. And those genetic SNPs start to show up. And what we see is that when we're going through hormonal shifts in life, those genetic mutations tend to express even more fully. So ultimately, what we would love to do is a Dutch test on everybody in their 20s, right? So we could see what their hormonal predisposition looks like. So we can essentially fill the tank before big life changes happen where we start to see hormones really shift and become erratic, neurotransmitters shift and become erratic, stress resilience become lower. How can we really help people even earlier in a perfect world, right? To really fill the tank and help them through these transitions really smoothly. If we think about our parents and our grandparents and our great grandparents, they were exposed to huge stressors in life, very different stressors from what we see now, but they didn't experience these same shifts in their hormones that we're experiencing. And it's not necessarily that we're not as tough or maybe not as resilient, but in a way we are not as resilient to stress because our genes have been modified by our food supply and by what we're exposed to environmentally. And then that's really amplified as we go through hormonal changes. Okay, so we're going to take a look at perimenopause, the transition from perimenopause to menopause, and what this case looks like. So, this case involves a patient who's in perimenopause. Um, Quality of life is starting to decline a little bit. We are starting to see at first things like anxiety and sleep problems, which are then usually followed by things like hot flashes and night sweats. So we'll see progesterone lower first, and then estrogen sometimes increases, or we're creating a relative estrogen dominance compared to that progesterone. So we have this hormonal imbalance that we see. Night sweats and hot flashes tend to appear when there's fluctuation in estrogen, or estrogen starts to stay toward the lower side. We see a lot of fatigue. We see cognitive changes. And from a patient perspective, this patient's goal was number one, symptom management. She was having a hard time living with herself, she said. Her quality of life was declining, and she couldn't figure out how to improve it, and felt like every month was different and she didn't know what to expect. And that makes it even harder to predict, right? Each day can be different. Each week is different. Each month is different. And if we have genetic data behind some of these hormonal changes, we can ultimately, hopefully, help her feel better faster. And then focusing on weight in both of these phenotypes in slightly different ways. So we want to look at all of these things, not only in the Dutch test, but if we can, genetically as well, to really help get her there faster. So this is what we see on the Dutch test. This is a 52-year-old female who was complaining primarily of anxiety, poor sleep, mood swings, fatigue, and brain fog. And what we see is that her CYP3A4 pathway is really upregulated. And also, her 4OH is not the best. That 1B1 pathway is upregulated. And one of the things that I love about the new slider bars, these are newer on our test. And one of the things I really love actually about working for Dutch is that we're always looking for ways to improve and become as precise as we can for you and for your patient. And we realized that the pie chart wasn't catching every single thing. And I love this case study because this is a great example of when we see her 4OH in the pie chart, it looks fine. It's only 4.4% of the pie. It looks nice and small. But when we look at the slider bar and we actually compare her to the patient population, we see that she's getting toward that lower end. She's getting closer to 408. So her ratio of 3A4, who has a really flat cortisol awakening response and not a whole lot of cortisol left to go around, who has a very slow COMT and low methylation activity, a very low progesterone, and also happens to have pyroglutamate that's above range. And pyroglutamate, when it's high, especially, indicates a deficiency in glutathione. And this patient happens to have a GSTM1 mutation, actually a null gene related to glutathione. So when we're looking at what we can do to help her, genetics are really helpful. So when we look at those three pathways, the 2OH, the 4OH, and the 16OH, we want to make sure that we are able to really create good balance. That 16OH is a hard one to manage. When it's that large, it makes it even more challenging. And the thing about the 16OH pathway is that we always want to make sure that the patient is not on a medication that's either inducing or inhibiting that pathway. If they are, then we don't touch that pathway. The neat thing about the Dutch also is that we know supplements, lifestyle, nutrition that will move all of these dials and move all of these arrows, either increase or decrease. But we always want to make sure we're looking through the lens of not only the patient and the patient's symptoms and the patient's genetics, but also the patient's medication. Really important before we start using a bunch of supplements. So if we can use lifestyle and diet, ideally in a perfect world, but with a blue pie piece that is that elevated, we need to figure out why, right? Is it just the CYP3A4 mutation, or is there something else that's happening? And then we probably want to redirect that pathway if they're not on a medication that's using that. And DIM is probably the best way to move that pathway from a supplement perspective. But we're going to talk about that in a little bit more detail in a couple of slides, because we need to be careful that we don't just put everybody on the same thing. We really keep in mind what their potential genetic predisposition could be if we don't have genetics on them. And flax seeds also very helpful from a dietary perspective to help pull that 16-OH over to that 2-OH. So when we have um, less ovulation, or more anovulatory cycles, the corpus luteum does not get produced. It makes progesterone and it is not formed in many cycles perimenopausally. Generally, it starts off as fairly irregularly. We're not forming that corpus luteum to make progesterone in that luteal phase of the cycle. And the further we progress through perimenopause, which can be 5 to 15 years before menopause. And most women are menopausal in the United States by age 50. So when I was talking earlier about filling the tank, this is a subset of the population that I feel like really could use to focus on hormones as early as possible, like in their mid 30s, right? Because they could be going through early phases of perimenopause. And if we can get them or look at their hormones when they're just starting to get dysregulated, it's definitely a whole lot easier to make changes and create better balance. So when progesterone lowers, we create a state of estrogen dominance, which makes irritability worse. Typically, it makes bloating worse. Breast tenderness is worse. Mood swings are worse. We have less positive interaction with GABA, which is what makes us not anxious and what helps us to sleep. When we don't have that same interaction with our alpha pregnenolone converting to allopregnanolone and crossing the blood brain barrier and having a positive interaction with GABA, it's a lot harder to stay asleep and it's much harder to handle anxiety in general, and keep mood stable. So when we have low progesterone, we always want to consider supporting with progesterone. Do we support with supplements? Do we support with bioidentical hormones? Everybody's different, but there are lots of ways to approach this. But bringing progesterone back up a little bit closer to estrogen can be very helpful for a lot of women. We want to help them manage stress and establish really good sleep hygiene if it's not already there. Remove any of the other factors that could be leading to poor sleep. Um, the room is too warm, or it's not dark enough, or we're using screens too close to bed. All of those things that can interfere with our melatonin production, screens especially. And things that are, getting in our way, we want to help them remove all of those things. Magnesium and B vitamins also can be very helpful. When we have a flat car, what this slide shows us is a healthy diurnal pattern or normal cortisol awakening response is represented by that dotted line. And then the pink is a low CAR, which is what we see in this case, in this patient. An elevated CAR is that blue line, and normal is somewhere in that range. But the CAR, which is what we see in saliva on the Dutch Plus, is a waking sample and then a waking to 30-minute sample and a 30 to 60-minute sample. And our cortisol peaks somewhere between that 30 and 45 minutes after waking. When you read research, it's going to show us mostly a 45 minutes, so waking in 45. So we want to get that really nice peak. And what we do with a Dutch test is we get an extra point. So we get to see the 30 and we get to see the 60. So this is how is the body responding to the day. And if you remember from our case study, she has a really flat response to the day, which is a blunted adrenal response, which is a lot of fatigue, a lot of feeling blah, but also feeling, in some cases, a little bit wired at the same time as exhausted. There's HPA dysregulation or HPA axis dysregulation, and fluctuating and lowering levels of hormones further disrupt the HPA axis, which make a low CAR even more disruptive to the body, showing up as irregular sleep. Especially poor diet and lack of restorative downtime can make things like a low or a blunted CAR even worse. And we have, as a society, I think, in a way, made busy popular and the thing to do. And not all of us are in the habit anymore of actual restorative downtime. So it's something to really keep in mind. The health impacts of a flattened car are fatigue and sleep disturbances. That rise and fall of cortisol in the morning is really what helps us to get to sleep and stay asleep ultimately. And it affects our mood. It's harder to keep a stable mood and not have mood swings when there's a flat cortisol awakening response or a blunted HPA response. And when we look at this patient in particular, look at her case and look at her CYP3A4 and her CYP1B1 pathways, we saw what was really obvious was a bigger blue pie piece. So we may want to say, or 16OH on the slider bar elevation. And what we may want to say is we want to jump right to dim. But what I've been seeing more and more, even lately, I think the more I focus on it, the more I see it on Dutch tests. And I'm lucky enough working here where I get to see thousands of tests, I feel like a month. So we get to see these examples over and over and over again. And what I've seen is that DIM and I3C, when someone has a genetic mutation on the 1B1 and we use DIM, we sometimes see, not in everybody, but sometimes, and this is where genetics are really helpful, we sometimes see an elevation in that 4OH pathway, in that 1B1, that one that can lead to oxidative stress and DNA damage when we use DIM. So it can actually increase that rather than lower it. So we want to make sure that we're looking at, to the best of our ability, do they show us this genetic presentation for the 1B1? And we want to be really more cautious with a supplement like DIM in patients with known high CYP1B1 activity, especially. So things that are really helpful for the 1B1. If you want to use DIM, and you want to be careful also, or conscious, I guess, of the 1B1, you want to use things like antioxidants. You want to use things like vitamin C, NAC and glutathione, calcium D-glucarate. One of my favorite things to use for that 1B1 is sulforaphane or broccoli seed extract. We can get that from a supplement or we can get that from diet. You can find it in high concentrations in broccoli sprouts, or those are sometimes more expensive and definitely hard to grow, at least for myself, trying to grow them. But if you're eating, let's say, broccoli or cruciferous vegetables in general, there's something called the hack and hold method, where if you cut that broccoli or those Brussels sprouts or that cauliflower and let it sit out for 30 to 45 minutes before eating it or cooking it, you can exponentially increase the sulforaphane content of those cruciferous vegetables, which is a nice hack for people who don't always have access to broccoli sprouts. So you can increase the sulforaphane that way. And this is the first time we're going to look at the COMT. We're going to look at it again in the male phenotype, but this is in the female, in the perimenopausal phenotype, we're seeing a slow COMT. And this little chart shows us the difference between a slow COMT and a fast COMT. Between a slow COMT and a fast COMT. So with a slow COMT, we have slow catecholamine metabolism. We have slower estrogen clearance, and mood instability and anxiety are very common estrogen dominant symptoms because those catechol estrogens can't clear out as efficiently. And we want to make sure that we're supporting a slow COMT with things like B vitamins, plus other things that can help with a COMT, phosphatidylcholine, methionine, et cetera. We'll talk about that in a slide coming up. And then we look at the detoxification. We know she has some mutations on the GSTs, the GSTM1, the GSTT1. When there are polymorphisms there, those show up as deletions. And they make the levels of oxidative stress elevate. And we also have on the Dutch test the 8-OHDG, which is our very last marker on page 6. So we can see how much oxidative stress is being produced by the body and how do we best help that. We also want to use diet, again, wherever possible. So for this patient, we can consider certainly bioidentical hormone replacement therapy, especially around progesterone initially, maybe eventually supporting estradiol that way. We also want to support their GABA pathways, which is something that oral progesterone does. And incorporating micronized progesterone into a BHRT regimen can be really helpful, related to both sleep and mood and anxiety, and assist neurotransmitter pathways. And then we want to look at, if we can, that GAD1 gene, which converts glutamate to GABA. Again, glutamate is excitatory, GABA is calming. So we want to look at what kind of mutations do they have? How overstimulated are they? How sensitive are they to stress? How sensitive are they to anxiety? How sensitive are they to sleep disturbances? Are they going to wake up and be up for hours? Are they going to wake up and be up only for a few minutes? Thinking about supporting that GAD1 with things like magnesium. GABA supplements directly can be helpful. And then lifestyle adjustments like breathing, muscle relaxation, mindfulness also can be really helpful here. So when it comes to supporting methylation, I put here methylation support with B vitamins, etc. And I put that etc. there because Dr. Tim on our team taught me this a long time ago. We get really hyper focused sometimes about B vitamins, B vitamins, B vitamins, and it's about way more than just B vitamins. If you ever want to talk methylation in detail, he is a great reference and a great doc to talk to. But when we're looking at methylation, B vitamins very important, yes, but phosphatidylcholine also very important. Methionine, magnesium, SAMe potentially the biggest methyl donor, and when we're supporting COMT, we can balance neurotransmitters better. We can eliminate estrogen metabolites even better. And where the et cetera came from, and I gave this its very own slide, is trimethylglycine. And one of the first things I remember talking to Tim, one of the first times I ever talked to him, he was talking about using 1.5 grams or 3 grams of trimethylglycine. And that's not something I had ever heard of, 9 years ago. That much trimethylglycine? Sometimes, yes, when there are genetic mutations and somebody doesn't tolerate B vitamins well, for example, they may need more TMG support. It's an alternative pathway which provides methyl groups without relying on MTHFR, which makes it, I think, pretty awesome, especially when we know there's a genetic mutation. And those people that just don't tolerate those Bs usually tend to be those people. When we look at CBS variants, certain CBS mutations increase sulfur load by upregulating the transsulfuration pathway. And TMG gives methylation support, again, without elevating those sulfur compounds, which some people can be sensitive to. So TMG is a pretty powerful supplement. Of course, not for everybody, but I love that it can be a workaround for some people who are having a hard time tolerating typical methylation support. So some stress management for HPA axis resilience in people who are extra irritated. Sometimes they will get even more irritated with you trying to suggest things like deep breathing and mindfulness. I don't have time for that, and I'm irritated about it, right? But those are usually the people who most need these types of lifestyle changes, really looking at things. And sometimes a hormonal shift like this is what it takes to get people to listen to those things, right? They're, pushing too hard and not really taking good enough care of themselves. So this is where we can really show them the Dutch test. And this is what your body is telling us. This is probably why you feel so bad. And here are some things that we know in the research you can do about it. Good sleep hygiene, also very important for this patient, having a consistent bedtime and wake up so that circadian rhythm is really nicely regulated, having a perfect, to the best of our ability, sleep environment, and making sure light is something that we focus on, not blue light, ideally 3 hours before bed. It's just like caffeine in the morning, ideally not for 120 minutes after waking. Those are hard habits. in our culture, usually, to get into, but those are two things that are really important for resetting that diurnal pattern. Also, physical activity and resistance training. If you've not seen Stacey Sims' work around perimenopause and strength training, I recommend it. She's pretty amazing. But hormones really affect muscle growth, muscle maintenance, um, mood, endorphin release. From exercise can be very helpful, can improve our long term resilience, and can help really essentially stabilize hormones in the long run. And then a couple of dietary things that we can use. Flax seeds are great. Seed cycling is also really helpful for hormonal balance, even in women who are perimenopausal or even menopausal. We typically use the cycles of the moon if they're not cycling regularly any longer, or don't know when they're cycling because they've had surgery. They still have ovaries, but not a uterus, for example. We can have, create better hormone balance with seed cycling in all women. Stabilizing blood sugar, really, really important. Making sure they're getting enough essential vitamins and minerals, making sure they're getting enough fiber to clear hormones out of the system, and healthy fats to promote resilience. And we're going to look next at the burned out male. And I really wanted to look at this, especially this month, because we're focusing on male health in general. And I feel like men are a really underserved population from a hormonal perspective, not as much as used to be. We're focusing more on it, but there are a lot of demands on men, women also, but men in a very different way. And there's a lot of pressure, and they're not used to generally asking for help with hormone dysregulation or, you know, neurological things, right? They, in some cases, were raised to be tougher and not quite as vulnerable around these things. And really testing them and looking at their levels is so helpful in helping them feel better. If we can get them actually to the point of testing. So this burned out male case study, he presented with chronic fatigue, low motivation, mood instability, poor sleep patterns. And when we looked at his Dutch and we looked at his genetic markers together, it was easy to see why he had chronic fatigue, why he didn't feel like doing anything anymore, why his sleep was disturbed. And ultimately, we want to also create in him hormone balance and stress resilience and better sleep. And when we look at his Dutch test, what we see is that he has really low testosterone, with a higher 5 alpha DHT and higher 5 alpha reductase activity. He has even higher estrogens and is not detoxifying those estrogens well. He has a flatter, still has a diurnal pattern, but a very low cortisol pattern and a lower cortisol curve, not having the ability really to hold on to that free cortisol any longer. He has a low end of range HVA and VMA, and he has a high quinolinate with a fast COMT. And you get to see some of his symptoms here. So he's 59. He is 67 inches and weighs 195 pounds. And he's primarily complaining of severe morning and mild afternoon fatigue with sleep problems, depression, lack of motivation. He's on Lexapro, he's on Cialis, he's on a statin, and he's on a beta blocker. So when we look at his findings, that low testosterone is contributing to his fatigue, his lower muscle mass, and higher estrogen contributing to body fat, extra body fat, which then further exacerbates aromatase. The conversion is even more exaggerated when there's body fat. So it's not the greatest feedback loop when it comes to body weight and aromatase. So we want to, consider things that are going to stop that conversion of testosterone to estrogen and create better hormone balance for him. So these are the aromatase arrows that you see on the Dutch test. And I have over to the side some aromatase inhibitors and aromatase inducers. And the CYP19A1 is what controls that aromatase activity. And remember, For the CYPs, they can only upregulate, they cannot downregulate. So we're seeing in this male, he has a mutation on that 19A1, and he has more aromatase activity, so lower testosterone and higher estrogen. So we would want to consider with somebody like this aromatase inhibitors. One of the great things about DIM is that it helps pull extra estrogen out of these pathways, and it also blocks aromatase gently. And chrysin is something else we typically use for aromatase. And then diet and exercise for somebody like this. That um, higher 5 alpha DHT, even though it feels more androgenic, can feel more androgenic in a way that causes more things like anxiety and irritability and energy instability when that's higher. From a mood perspective, in addition to putting the prostate at more risk. And what controls that is the SRD5A2 gene. So we want to look at using things for patients like this that will stop that conversion over to alpha and push things more toward beta pathway. Things like saw palmetto and stinging nettle, reishi mushroom, and pygeum are really helpful in slowing down that conversion to alpha and redirecting things to the beta pathway, reducing stress in general, um, stress reduction, lifestyle can be very helpful. Increasing physical activity also can be very helpful. We also can consider supporting this male with hormones, testosterone, while we're blocking the conversion of that testosterone via aromatase. Myomin is another supplement that's used occasionally to block aromatase. So we want to increase androgens, testosterone especially, and reduce the amount of estrogen in order to help create better hormone balance for this patient. And he also has that flatter cortisol curve, really a lower cortisol curve with a lower DHEA. So that blunted cortisol response makes him less resilient to stress in general. Low DHEA means that he can make less testosterone from his own hormones. We want to support those adrenal glands as much as we can without overdoing, right? We always want to be careful when we're supporting adrenals and only do what we need to do, because the body is so wise, it will turn off adrenal production of cortisol on purpose when stress is too chronic, or even in acute stressful situations. After cortisol goes up, it will lower. The body will protect itself from becoming hypertensive, for example. So things like ashwagandha, which work on the hypothalamus and pituitary, the start of that HP, right, to adrenal axis or to gonadal axis. It's the same axis, same as also to thyroid. But things like ashwagandha can really help regulate from a brain perspective. So adaptogens can be helpful. Sometimes even things like glandulars and or in the short term and licorice, if appropriate for the patient, can be helpful in helping them hold on to a little bit more cortisol. And then this patient has a fast COMT. He has the VAL-VAL genotype on the COMT, which means that he metabolizes his catecholamines like dopamine, epinephrine, and norepinephrine much more quickly, especially as compared to that perimenopausal female phenotype. So we have lower levels of those neurotransmitters in general, which can make sustained focus more challenging, motivation more challenging, make mood less stable. Dopamine is, the reward neurotransmitter. It's involved in drive. So we have less mental clarity, more fatigue in general, lower drive in general with a fast COMT. So slowing down the COMT can be very helpful in patients like this. So when we see a low HVA and a low VMA and somebody who's presenting with low motivation and focus, we want to focus on things that will help to support dopamine, which converts to epinephrine, norepinephrine, using things like tyrosine, L-DOPA, B6. We want to limit stimulants, which cause even more rapid depletion of neurotransmitters, dopamine, especially thinking about things like magnesium and adaptogens, again, making sure they're eating a protein rich diet. They are practicing using mindfulness practices in the day to day, are exercising regularly, using things that we know to help support their neurotransmitters in general. And then this patient, our burned out male, also had high quinolinate, um, which is a neuroinflammatory marker. And things that can be helpful to lower quinolinate are good sleep, our blood sugar regulation, and moving, exercising in general. A quinolinate elevation can cause brain fog, it can cause mood disturbances, it can cause fatigue in general, and it's very highly inflammatory. And really, it's neuroinflammatory, which makes it even worse, I think, than general inflammation, even. It overstimulates NMDA receptors, which creates excitotoxicity, and focusing on reducing the cause of the inflammation primarily, but also potentially using anti-inflammatory nutrients like curcumin and omegas, and helping manage stress a little bit better, and ultimately optimize sleep can be very helpful in the burned out male phenotype. We want to look at why they're more vulnerable to stress, right? And fix things if we can, or help them support those pathways, looking at things like the NR3C1, looking at things like the FKBP5. He happens to have mutations on both of those, which change the way that he really responds to stressors in general. How does he respond to it? How quickly or really tightly does the cortisol bind to those receptors? And then how long does it stay there, right? Those all make a difference in how well we can handle fatigue and how quickly it leads to burnout over time. So we want to make sure that we're addressing all of those things with the burned out male phenotype. Um, Other methyl donors, like we talked about before, SAMe is a great one. Enhancing resilient to stress is very helpful in supporting dopaminergic function. Helping them manage stress, really good sleep hygiene here as well, really for everybody, as we know. And then giving them really targeted exercise programs to help in general. And when we look at these case studies and we look at the genetic data combined with the results on the Dutch test, and we come back around to what we're looking at these pathways, and this is a summary chart here for you that looks at the hormone pathways and the pathways that they share together. So when we're looking at these things, it's not just about, when we're looking at methylation, it's not just about methylation. It's also peripheral to glucuronidation. It's peripheral to sulfation. It's peripheral to glutathione conjugation. It's oxidative stress levels. It's all of these things together that cause a specific presentation in the patient. So if we're looking at all of those pathways, which we look at when we're looking at Dutch, and then we look at genetics with those, we can see a much bigger picture of how to help the patient in general. So if we review those case studies, the perimenopausal female, mood swings, hot flashes, fatigue, and cognitive difficulties, and her care plan intervention included BHRT, antioxidants, methylated B vitamins. And the burned out male presented with chronic fatigue, low motivation, and mood disturbances. And some big keys for him was, one thing was also BHRT, testosterone support, inhibiting that aromatization, redirecting that alpha pathway over to beta to reduce that 5-alpha DHT and that really potent alpha pathway, adrenal support, and catecholamine support. So each of these cases gave us the ability to look at these really specific symptoms, but tie them to genetics that will influence those things and make those things happen faster during life transitions. So if we can combine, ideally, genetics plus the Dutch testing for precision care, it allows us to create really tailored, specific protocols that address each patient's unique biochemical needs. And integrating those together helps us even to get there faster, so we can enhance the patient's resilience to stress. In that perimenopausal female, We got to see how much she needs methylation support and antioxidant support through genetics. But then the Dutch test really showed us in an even more targeted way in real life, how is she handling her hormones? How is she detoxifying and methylating her hormones? How is she handling her antioxidants? What does her comps look like? And we got to see really not good, right? And we got to really target her care based on that. For the burned out male, we saw that he had high aromatase activity and impaired catecholamine turnover based on his genetics. And then the Dutch showed us those things in real life. We got to see, yep, his estrogen, his estradiol in particular, was definitely elevated. He had low epinephrine markers, low dopamine markers. He had that lower HVA and VMA. So we really focused for him on testosterone support, aromatase inhibition, and adrenal resilience through stress management and lifestyle. So combining those two, the genetics with the Dutch test, really, if we're able to do that, and we're lucky enough to have all of that data on our patients, it allows us to use a combined approach, which really helps us to address ultimately the root cause for the patient, and to optimize their health outcomes ultimately, which have been tailored very specifically to each individual's genetic and hormonal profile. And I promised we would come back here. I want to emphasize again that understanding this interplay can feel overwhelming, right? It's like looking at the Dutch test for the first time, it can feel overwhelming. But the more you see it and the more references you have, and the easier it is to read it, the easier it becomes. Over time, it's easy, right? It just takes that repetition. But it's hard as providers, as we know. It's like one more thing to learn, right? Oh, now I need to learn genetics. So we have these charts that are um, helping you as a reference, hopefully in practice, when we're looking at genes and, what do I even do about it? How do I know what to do? We always want to look at actionable data. And that's one thing that the Dutch we know gives us is really good actionable data. And I hope that this helps to make genetics a little bit more actionable for you. And as we wrap up, I want to take just a moment to talk about something that I'm really super passionate about. And it is the Dutch test and the incredible community of providers who use it. If you are not already a Dutch provider, I really strongly encourage you to consider joining us. The Dutch test really is not just a test. It's way more than a test. It's a powerful tool in functional medicine that gives us really, I think, extraordinary depth. Of insight, frankly, on patients that goes way beyond just sex hormones, just adrenals, just neurotransmitters and organic acids. What makes the Dutch test so special is how comprehensive it is, from looking at hormone metabolites, right, which you don't usually get to see, to neurotransmitter markers. It allows us to see the intricate connections in our patient's health. It's almost like there are gems hidden within the test results, insights that we can overlook by doing other types of testing, but are so critical to really, truly, comprehensively coming up with a treatment protocol for the patient. And really, I think one of the things I love so much about working for Dutch is that beyond the test itself, becoming a Dutch provider means that you become part of a community where you're supported at every step we possibly can support you. We know the depth of this test can feel complex, especially when you're just beginning. And that's why we provide the interpretive guide to walk you through each part of the report. We have a mastering functional hormones testing course to deepen your understanding. And we have group mentorship sessions and lunch and learns throughout the United States, especially in 2025, where you can learn in a collaborative environment. And one of my most favorite things about Dutch, and why I love working here more than any other reason, I think, is my connection and our connection to you as providers. So when you become a Dutch provider, you're not just on your own with a report. You have direct access to not only all the resources that we have for you, but also to our clinical team of doctors who are ready and so excited to support you. We offer scheduled consultations, which allow us to dive deep into cases together. And we have a same day callback service. You just give us a time window and we call you back to discuss results, answer questions, help you to feel more confident about interpreting the test and coming up with a really robust protocol for your patient. And it's a chance for us to get to know you as well, to learn about your practice and how we can best support you and your patients. So if you're feeling inspired by what you've learned today, hopefully you've learned a couple of things, or at least been inspired by looking maybe more at Dutch testing, especially in men, or even pairing that with genetics, and want to bring this level of insight and depth to your practice. I'd love to see you join our community of Dutch providers. It's a path to not only enhancing patient care, but also connecting with a network of truly like-minded professionals who are super passionate about transforming health in this country and worldwide. So thank you all so much for your time, for your engagement, for staying with me, and for the work you do for your patients every single day. I would love to keep this conversation going. I can't wait to answer some of your questions, and I look forward to hopefully connecting with each one of you really soon. Thank you so much.
Thank you, Dr. Christina O'Brien. You were so knowledgeable on genetics, and we always love learning from you. And thank you to the listener, to you, for joining us for this insightful webinar. We hope you learned something helpful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research, and make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.